To make a very simple presentation about UBE. This presentation will be especially for our young brothers under 40 years who will see in some 2-3 years, maybe in some 5 years, that everything in our operating rooms and in our surgical practice, especially for spine surgery, will change. So I was very impressed when I seen for the first time this technique, this bilateral technique, because I start to make endoscopic spine surgery with unilateral technique, with transforaminal surgery and with interlaminar surgery. But as you know, especially with the transforaminal surgery, our indications were very limited, especially to the foramen, to the lateral side of the foramen. So, so let's talk a little bit about what is UBE and why we use it. First of all, our respectable professor will now better than us. Normally when we are doing an open laminectomy, anesthesiologist ask us to have minimum 2 or 3 units of blood before surgery, and if everything is not okay, if everything is not ready, they don't accept for the surgery. This surgery is very important, especially for 2 or 3 reasons. First, there is no bleeding. A laminectomy for stenosis or a disc surgery without any bleeding is very impressive. Second, there is not a big risk of infection because fluid circulation. And third, our respected speakers talked yesterday and today about importance of paravertebral muscles, about multifidus muscles and damage. So this surgery give us the opportunity to make a surgery without any muscle damage, who is extremely important for the spine biodynamics, spine stability. Okay, is it a new surgery? No, this is not a new surgery. As you see here, the first publications are very old, not very old, but they are not very new. But especially for this last years, this surgery is used by Korean surgeons. It was developed with some new technologies, Korean technologies. But here, one of the first publications about this surgery, about this surgical technique, who say us that this is not a new surgery. Is it a full endoscopic surgery? No, unfortunately, this is not a full endoscopic surgery. This is the classification of our spine, and as you see, UBE is classified by endoscopy assisted surgery, but monoportal surgeries like transforaminal or interlaminar surgeries that you will see this afternoon, they are classified like full endoscopic surgery, but this classification say us that This is not this is not an endoscopic full endoscopic surgery. One of the main advantage of the surgery is that we can easily, without buying any new instrument, expensive instrument, we can use the instrument that we have in our operating room. For example, we can use this arthroscope. In general, we use 0° of arthroscope, 0° or 30° of arthroscope we are using. So we connect a camera, a light source to the arthroscope. So approximately in every operating room who are doing arthroscopic shoulder surgery or other or ENT surgery, there is this kind of arthroscope. No need to pay many thousands of dollars to buy a new spine endoscope to start to the surgery. We use also, I will show you, okay. We use also some arthroscopic burrs, some arthroscopic drills for the surgery. I will show you. We use also a radiofrequency system for two reasons, for dissection and for coagulation. There is some special instruments for UBE, but no need to pay for them. Essentially, these instruments are for tissue dissection, and you can easily use some simple instruments that you have on your operating room. You don't have to buy in the beginning to pay for instruments. Okay? So, as I said, our target is a target between the spinal process and the multifidus muscles. There is a virtual triangle. As you know, when you make an open surgery, first you start to cut the attachment of the multifidus to the spinal process. Here we don't cut it, but we distract slightly and we go to the spinolaminar junction. When we go to the spinolaminar junction, here normally there is no space to work. It's okay, it's okay. There is no space to work. So we have to create a space, a working space. This is Dr. Song from Korea. He's a very experimental and very respected neurosurgeon, and he's working about development of UBE, and he gave his name to this area. Now in scientific area, in spine scientific area, we say the strong space, the virtual space that we create. I will show you how we create it. As I said, as I told you, we cross between this multifidus muscles, and we use this chakra also. And more important than we use the water. and with the water pressure and with the distraction, we create a working area at the junction of the lamina and spinous process, and we start to dissect it. I will show you. Here is our first target for the beginning of the surgery. Okay? The first one is the fluid entry. Is our working. Is our camera is our scope channel. The second one is our working channel. So there is a fluid circulation. Here is our entry and here is our exit. Okay, it's very important to understand it. Why? First, this is because this fluid circulation that we don't have so much infection problem. Second, this fluid pressure give a kind of hemostasis with the compression on epidural vein. This is why we don't have so much bleeding during this surgery. But it's very important to have an equilibrium, an understandable equilibrium between the fluid entry and the fluid exit. Why? Because if we don't have this around 50 milligram of pressure, we can have some complications. Because if we have a big pressure on nerve tissue, on blood tissue, we observe some epileptic seizures, some optic nerve damage, some postoperative serious neurological complications. So it's very important to have a fluid entry and fluid exit under our control to not have big neurological complications after this surgery. So, how we do? As we talked yesterday, we must have a correct AP and correct lateral view. So, we see the superior end plate and the inferior end plate. Okay? So, to have this, we give a craniocaudal angulation to our fluoroscopy, and we must have a correct AP and also a correct lateral fluoroscopic view. And after this, we see our midline, because we make a surgery without any visual control. Our main control is fluoroscopic. So standard X-rays are mainly important, even more important than MRI for us for the preoperative evaluation, because the fluoroscopy will give us the same views. So we have to work not only on MRI, but also on standard X-rays with AP and lateral views. And after tracing the midline, mid-pedicular line is very important for us. Why? As I will show you, mid-pedicular line will give us our entry points and exit points. We will make two small incisions of around 1 centimeter. So for median approach, not for paramedian approach. I will show you all of them. And here, this is the junction of lamina and spinous process when we will meet with our instrument, with our camera, and with our radio frequency probe or Kelsen probe or whatever we will use. It will be our meeting point, so we will make a triangulation at this point, okay? This point is important. Here will be our first incision for our camera near the pedicule of the upper level. And here will be our second incision, okay, for our triangulation. Same for the lateral views. We will meet here in this point. We will make a triangulation. And between our two incisions, we will have around 3 centimeters, because if you have an obese patient, it will be a little bit more. So these 2 blue points will be our 2 entry points. This is for paraspinal approach. If we want to make a surgery for a extraforaminal disc herniation or foraminal stenosis, so we will meet here, and then we will make 2 small incisions to meet, as you see here, at the upper part of the foramen. Okay, let's go to the operating room and see an abstract of surgery with some small videos. This surgery, normally I use it for dissection and for stenosis. Sure, monoportal approach, transforaminal or interlateral, are less invasive than this surgery. Okay? So if it's possible for me to make a monoportal approach, I prefer this. But learning curve of monoportal approach, especially of transforaminal approach, is a little bit long. And the transforaminal anatomy can be difficult for a baby. But here, as we will see, this is the anatomy that we learn because we make open surgery, microsurgery, microdiscectomy, open laminectomy, especially for neurosurgeons. This is another area, an anatomy that we are able to handle. And for babies, it's a very attractive surgery. For neurosurgeons, especially transforaminal endoscopic monoportal surgery in the beginning, it's very difficult because we are not familiar with the endoscope, we are working with the microscope. Endoscope is different for us, and the anatomy of transforaminal can be different. So, but this is a very attractive surgery for surgeons who know their anatomy because there is very large vision. For many cases, we put interbody cage by this way, and pedicule screws, also percutaneous screws, so we are able to make surgery of spondylolisthesis also with combination of transpedicular screws and this surgery. We don't have bleeding, we don't have infection, and we have a quick recovery. We have a better quality of life of the patient after surgery. And you imagine we make a laminectomy with these two small incisions, and I use mainly this surgery for stenosis more than this herniation. We are bilateral decompression. To be simple, I showed you only a simple disc herniation, but we are able to make a bilateral decompression of one level, two level, three level, up to you with these small incisions. So one is called portal, and that vertic portal. They are unable to make the work necessary, but combination give us a good opportunity. I think it's a nice surgery, especially for the beginner, because learning curve of transferring that even interlunar monofocal is more difficult, and this is relevant with you now because you are working for many years. So this is the beginning of the UBE, and I'm sure in some years with the robotic surgery and with the artificial intelligence, we completely stop to make the honest surgical technique, and we have to adapt the robotic surgery, the endoscopic surgery, and artificial intelligence, and in fact, any station we continue to make these surgeries, and we will have less complications, because when I have a ring on my hand, I can make any mistake. But with robotic surgery, it's approximately not possible to take you forward that.
Excellent presentation. I have just one comment.
Yes.
As we know, a new surgeon here and spine surgeon.
Not only also orthopedic surgeons have cases.
I see Leo and spine.
Yes.
Okay. We believe that our surgery in the spine is decompression. We believe that we make root, we have done for measure. We believe also that compressing is the bone. It's not root. It's not only the bone. If you don't know about ligaments that attach the root in its close, you don't see, you don't do all your mission. You have to see your root free and pulsating. This is the decompression that we are talking about in endoscopy. This is something you can't see by microscopy. Thank you.